let's go ahead. More people will probably come in, but it's good to get started. So welcome everyone to today's webinar on Analytic Imaging Diagnostic Arena, or AIDA, a national triple helix community putting AI. Huh? What did you say?
Hello, Joel.
Oh, hello, Joel. Putting AI to use in Swedish healthcare. Yeah, so today we have Joel Hedlund as the moderator. I think we're all familiar with him as a work package 2 lead. So Joel, if you would like to introduce yourself, and also today's speaker, Klaas Lundström.
Yes, I am Joel Hedlund. I am work package 2 lead in Bigpicture. I am also the lead of something called AIDA Data Hub, which is a mini Bigpicture in Sweden. We have a secure compute environment, just like Bigpicture does. We do data sharing, just like Bigpicture does. We do radiology and pathology. But in principle, you can see it as a proof of concept or demonstrator that something like Bigpicture can actually work in practice, at least in one country. So the infrastructure that I run exists to support AIDA, the Analytical Imaging Diagnostics Arena. So I am data director to AIDA, and Klaas, my colleague since 2018, he is a director to AIDA. AIDA does a lot of really cool stuff, which I'm always excited to hear about, even though I already know about it. So take it away, Klaas.
Thank you so much, Joel. So let's share. Is that working?
Yeah.
Lovely.
Perfect.
Maybe to add, if you have any questions, just go ahead and raise your hand. And
Great. So let's get started. First of all, let me just tell you I'm very happy to be here. I'm very happy to be part of Bigpicture and to tell you about what we've been up to on the national scale for a few years now in AIDA. I have two jobs. I am in academia, adjunct professor at the CMIV Center at Linköping University, and in industry, research director of Sector on the medical side, and both organizations being Bigpicture partners. And then, as you will said, I'm the overall director of AIDA. But the most important part of my CV is actually quite recent. Since earlier this year, I am, of course, the Bigpicture ambassador of 2023 with us. Very nice medal achieved in Vienna. All right, let's dive into it. AIDA, why? Why did we start AIDA? What is our mission? Well, our mission is to put AI to use in diagnostic imaging. And we have been using this illustration ever since the start, actually. Back in 2017, we already saw this, that we had so much potential in AI. We had so much very impressive results on the research sandbox side of things, but very, very few solutions were actually being put to use in the clinical wilderness. And this gap and this chasm is still there today, even though we have made progress, definitely, and the character has changed, and we have explored and understood other parts of that gap that we didn't really had come to in 2017. So that's what AIDA is about to tackle, and we're really taking a grassroots focus here. We are thinking about all these individual innovators in both healthcare, academia, and industry in Sweden, trying to bridge this gap. What can we do? Joining forces, what can we do to help them in different ways, tackling these obstacles? So I have structured this presentation in this way, that really specifying that a need that we identified and that we're trying to address in different ways. And the first one of those is really the overall observation that crossing that chasm cannot be done by any individual or any single sector even on its own. So healthcare, academia, and industry need to join forces. And that's not so easy to do always. And there was a need we felt to really have a very inclusive arena to organize this exchange within. So that was the start of AIDA, a national neutral arena, but also with tailored incentives for each sector, because not this sector, they won't have the same reason for being part of AIDA, but we need to make sure that AIDA can have those incentives for everyone. So this is AIDA today, a collaboration arena. We have around 50 partners or 50 partner organizations that are actively in agreements in the formal consortium, fairly evenly spread between academia, healthcare, and industry. But as you see on the map there, that's the colored spots of those organizations. But we also reach all the rest of Sweden through other types of activities. So the smaller circles you see there are participants in our different events, etc. So not all are formal partners, but are also part of AIDA. And as you can see, we're fully spread across the country. Where you see the dots are made basically where you have the university cities, university hospitals, and where people in Sweden live, more or less. So we coordinate this out of Linköping from the CMIV Center and a small management group. But very importantly, this is a national organization, and the governance, the strategic decisions are made by steering group that is fully national. And we also have a clinical council of clinically active radiologists and pathologists that we ask about, different strategic decisions, what should be our priorities, and we really want to keep that clinical relevance in everything we do. And we've been around since 2017. So the overview of what I will be talking about is the different parts of AIDA. We've evolved into two halves, we can say. And on the left-hand side, you see the AIDA program with a lot of this cross-disciplinary interaction. And this part is a part of a national strategic innovation program called MedTech for Health, and is funded by Sweden's innovation agency, Vinnova. And then you have the part, Joel is responsible for the data hub. That is part of a national research infrastructure, SciLife Lab. And actually, I will focus mainly on the left-hand side, as you probably heard a bit about the data hub before, and that's very close to what Bigpicture is developing the next generation of, but I'll make sure to mention it briefly as well. All right, so a really basic need that we identified early, and yes, it's also, of course, been identified over and over again in many parts of the world, is that in order to really reach clinical utility, clinical use, healthcare needs to be in the driver's seat for AI innovation. And that was not the case when we started, still needs to be addressed, but very much we felt it was technology-driven development. It was really strong AI results, but not really starting off in the right starting point with the real healthcare needs. So one way that we have answered this is to make sure that all the projects that we fund within AIDA needs to have really proper clinical relevance. So these innovation projects, they are where the bulk of the AIDA program funding goes to. It's partial funding to these projects. Typically, they are led by technical researchers in academia or industry. But as I said, it's completely mandatory that you have clinical engagement in these projects. There need to be clinically active counterparts who know the clinical realities. They need to put hours into the project, and also even before the project, we must see, or the steering group must see, that there is a well-developed clinical use case in mind that is really motivating and guiding the setup of the project, because we know that this is so important for in the end being able to actually turn this solution into something useful. So we include any medical imaging dominated by radiology and pathology, but we have examples that you see here as well on photos of wounds and dermatology, ophthalmology, etc., etc. And the main reason we have this scope is we've allowed to be as inclusive as possible with applications we feel that there's a lot to learn from each other, and where the basic methods have similarities that we can learn from each other. And then we have a educational need that we're addressing, and it's a dual one. Partly that healthcare needs to learn about AI, and even more so a few years ago, but also the computer scientists need to learn about the diagnostic workflows in order to really make this happen in a good way. So our answer to that is to have a really active meeting place, and we made it mandatory. It is something that is very, very appreciated. People coming to our events that I'll describe in a second. But still, if it wouldn't be mandatory, we all know how our calendars work. It's very difficult to prioritize. So by making it mandatory, then people get there, and then we get that critical mass, and then we get that high quality of exchange that we want to have. So our workshops are up to 8 times per year, and most of them are on site. We really believe in that still in this day and age, that we need to meet, and a lot of the value of these workshops are in the coffee breaks. They have different characters, so some of them are directed to all the data community with broad cross-disciplinary workshops, but we also have in-depth workshops targeting technical or clinical issues. And just a couple of examples is in September here, we have had a directed technical workshop on advanced deep learning, and we organized a few sessions on the Swedish Radiology Congress, more on the clinical side of things. But that basic understanding is, of course, a necessity for a broader group in healthcare. But we also saw that in order to have these innovators, these leaders in healthcare, they need to take one step further in their understanding of AI. So that's why we organize competence development for them. And this is mainly in 2 ways. One is an AI course that we have. It's a 3-day course for healthcare professionals with actually some hands-on AI training and lab work that is a bit unusual for them, but very appreciated, and a good starting point for communicating with the AI developers they will be working with. We've had this for 9 times over the years, and 10th time is coming this fall. And we also have fellowship projects, and that is AI development projects for healthcare professionals, where we don't really care about the novelty of the AI, but more about the learning outcomes of the project. And then moving on over the years, some topics have risen as more and more important, and the last few years, validation of AI has been such a topic that really has been something we need to develop and exchange knowledge about. And we support it in different ways. We have clinical evaluation projects that we can get funded. You can get funded through AIDA, evaluating commercial products before procurement, which is something that healthcare providers need to do. And the very simple but very appreciated part is what we call the AIDA list. Simply gathering all the evaluations and deployments of AI in diagnostic imaging in Sweden. They report it to us in a simple form, and we share it on their behalf in a simple PDF. But it's very appreciated, even though such a simple thing. We also did a strategic effort in. We felt that the quality assurance understanding of what quality assurance in AI was actually quite narrow, but a bit different depending on who you asked. So this was an effort to kind of map the full landscape of QA and AI that we did within AIDA that you can read more about in that paper. And then we are shifting into the domains of the data hub. And one major headache was, of course, the legal side of things. Not the least, how can we handle sharing of data from clinical sources, etc. And we have some challenges in Swedish legislation that everybody agrees on what you can't do, but we should be able to do. But there is also a lot of uncertainty and confusion about the current legislation, what it actually means, how to interpret that. So our answer to that was to jointly develop common guidelines for the benefit of everyone. So we developed this under US leadership, a data sharing policy. And the policy can be different things, but this is a very, very practical guide for anyone doing research on imaging data from clinical sources. Obviously, it has both European law and national Swedish law relations, but we believe that it probably is quite useful for many countries with similar data laws that's in Sweden. So it's openly available on the AIDA website. Please have a look if you like. It's quite practical. As I said, how should one think about anonymization in our domain, and how do you go about doing a legal and ethically sound project, etc. And we also wrote about this in a paper in Scientific Data to highlight some of those insights. And then we have the sharing part, obviously part of the data hub, and this free service we have is really about trying to solve all the technical and legal matters in the central place at the AIDA data hub, so that researchers don't need to develop this from scratch every time. They get a digital object identifier for their data sets, and on that register, there are now 23 data sets and 12 terabytes of data having been shared to 29 countries in 170 sharing events. And as you said, this was a prototype for what we're trying to expand in the next generation in Bigpicture. And also, I don't know how you have it in other countries, but having access to compute systems for larger training efforts, that's troublesome for researcher due to the cost involved, but also due to how to handle sensitive data. And this is something that you will set up based on this DGX2 server that is now being, a new generation is being designed and procured. And this is quite a rare thing in Sweden, that you have a national share resource, and also that it is safe enough to use for sensitive personal data. And apart from the actual technology here, we have DevOps and research support engineer to help out in running this and helping the users around the country. So the summary of this part of what the core of AIDA has done, during this year so far. So it sums up to 75 projects or so, and you see the numbers here. We're quite very happy with the type of outreach and the size, the volume of these things, and how many of, for instance, the Swedish workforce in radiology and pathology that we have actually reached by our efforts. What I'd like to spend a few minutes on is also what is actually beyond the core funding of AIDA and the core AIDA activities, because as we realized more and more, this AIDA has also become very important as a stepping stone to accelerate, initiate, and be synergistic with other efforts. And of course, Bigpicture is the best and biggest and most shiny example of that. But also a number of other initiatives. We have the EU project UCAME, which is similar to Bigpicture in some senses, and where the AIDA Data Hub will contribute Bigpicture-like services also for radiology. We have national infrastructures that we're working together with. NICE is the high-performance computing organization in Sweden, and Linköping has the leading role there. And if you're into the HPC news, you would know that the next big European supercomputer was awarded to Sweden in a decision this June. So this is something that we will be working closely with and helping them, making sure that our experiences with sensitive data also can go into these huge environments. We have the Data-Driven Life Science program, which is a big national initiative in Sweden. We're also working with the SCAPIS project is a huge research project in Sweden with 30,000 participants, including gone through lots of examinations, including imaging exams for cardiopulmonary disease. And AIDA is now a strategic partner to SCAPIS to help them share their imaging data with researchers around the world. And recently, this initiative was started from the Swedish Childhood Cancer Foundation. They want to unify the research access to all data on pediatric cancer in Sweden. So this is in itself a very valuable accomplishment if we can come there, but also we have this integrated diagnostics aspect that will be combining radiology, pathology, and genomics and other omics on the broad scale here. And AIDA has been identified from the Childhood Cancer Foundation as a strategic partner in this pre-study. So we're now starting work on the technical designs here. And let's spend a couple of slides on the validation parts as well. We, on a separate government-funded project, we started a project there where AIDA is the incubator for a number of 3 national AI validation platforms, because we identify that it's very difficult for especially the smaller care providers to do the necessary validation. The CE mark of a product goes to some extent to guarantee the quality, but we now know that you will have changes and surprises in the local environment with the local equipment, the local population, and you need to make sure that what you're using is safe and effective. So the national platforms is a way to join forces and make this possible for everyone, collecting representative data for any care provider on a national database, applying scientific methodology and building a technical infrastructure around this. And the first and biggest pilot for this is in mammography screening. It's called VEB. And if you've been following the AI in medical imaging news, you know that there were 2 major prospective clinical trials in mammography AI that came out this summer, both from Sweden. So one from Lund University and one from Karolinska Institute, and both those research groups are in this project running this platform. So we're very advanced in that sense. So with this platform, you can do actual studies on representative data for your specific care provider, actually getting what will be the effect if we would use AI in our setting. And this is one example. If you would, for this care provider, you would, if you would replace one of the radiologists in this double reading scheme with AI and have the same specificity, you would actually improve the sensitivity of the full pipeline, and obviously save a lot of time as well. But also going into quite detailed analyses that we didn't really know about before. So this is an example of how these AI suspicion points that you see on the y-axis here from 0 to 100, how they distribute for healthy and for cancer patients. So we want healthy to be on the low side and cancer to be on the high side, but for two different modality stand vendors. And if you have what you do today, you typically set the same threshold for any equipment. But what we can show here is that it's quite a different distribution for these different stands. So if we want to optimize the performance and have the same operating point of sensitivity and specificity for both stands, we actually would need to set different thresholds for different modalities here, which is interesting data to have, and really good for the decisions that these care providers need to take on how to run their AI. So to conclude, so many interesting aspects, so many interesting things to do, but it's really good also to take a step back from time to time and remember why we are doing this, the overall picture. And one example within the AIDA community that really makes me happy is to see where we have managed to assist an AI journey all the way out to patient benefits. So this is from a smaller hospital in Sweden in the city of Halmstad. They started their AI journey by participating in the AIDA AI course. They participated in an AIDA AI showcase event where they got in contact with a AI solution vendor that they were interested in. They started working together. They implemented this pulmonary embolism tool, did the clinical evaluation, implemented it, and could last year then create the evidence and prove that they did achieve the patient benefit that they wanted. In this case, what you see in the graph here is incidental pulmonary embolism findings. The turnaround time from that having gone from a number of days down to 15 minutes, which is kind of useful because then even the patient is still at the radiology department and can get the message to go to the emergency department instead of going home. So this is what it's all about. This is about getting AI to use and really provide value to patients, and we're happy to assist in this journey. Thank you so much.
Thank you, Claes. Amazing. Do we have questions from the audience? Because I have a few, but I don't want to go first. I will ask a question anyway and let people think about questions in the meantime. So why do we do it? You mentioned incentives earlier in your presentation, and you also mentioned validation of mammography and other AI algorithms. This is quite similar what's being done for validation as Bigpicture is planning to do for indirect access to AI algorithms and indirect access to data sets, like being able to try out an algorithm as a service before you buy it. or being able to benchmark your AI product against highly annotated, curated, very well understood data sets to learn about the performance of your tool in a new market, say. So could you say a few words of why people from different backgrounds would engage with a validator like this? Why would a company come there? Why would a clinic come there? What is in it for AIDA and so on?
Sure. So yeah, it is different use cases and different values to it, but the primary one that has been in focus for our effort has been the care provider that needs to know if one thing, if this solution is gonna have a value for us, or benchmark different solutions, would they all be relevant for us? Or going into details, how should we set this up? It could be different workflow options. In mammography screening, you have what I showed was the option where the second reader is replaced by AI, but you also have, as was the case in the Lund University study, that you use AI to triage and select paths depending on that. And all these things can be simulated quite well in these with these data sets. So all of these pre-procurement stuff is really useful for the care provider, but also for the companies, I would say. And I mean, it is obviously the companies have good control over the studies that went into their CE marking and quality assurance, but they also know and are facing different scenarios, different populations, differences when they come out to each and every place, and that's just going to increase that problem because the new versions of the equipment that will be out there in a year from now is going to be definitely different than what they had when they got their CE mark, etc. So if you're really taking the customer success perspective, this should be really interesting for the mature AI company that sees in the long run what is the best for everyone, even though it is of course an investment to take the time to learn more about the details of how their product works in different settings. So yeah, definitely value in both of the sides, scenarios, and you could also think of services to the AI vendor of actually providing training data, but then that would be a different data set than the validation data set, obviously.
Thank you. I see my fellow Joel has his hands up here.
Yes, thank you, Klaus. Very nice presentation. I'm glad that you mentioned this with the companies and what's in it for them. What would be the incentive for me as a top executive for a startup company in the AI healthcare sector to do this? As you mentioned, we could have like a very limited budget, and we think that we have an excellent product and everything looks great, but what could we do to incentivize them to help us help the patients, if you know what I mean, Klaus?
Yeah, sure. And I think it's a maturity thing. I mean, all these companies have been so busy and seeing that first peak of crossing that CE mark, and that was the big thing they worked on for several years, and that is obviously a big thing. But as we are maturing, we need and they need to see the longer, the bigger picture of that. We cannot accept solutions that we don't have control over the quality, etc. And I think it also goes in line with what a modern company should be thinking about, that this is a partnership. This is not we sell you a box of things and then you go use it, but we have a partnership in making sure that this turns into really optimum use for patient benefit. And I think that partnership also comes into that you need to evolve on how you design these workflows, and how do we cooperate between the man and machine in different ways, and how do we organize triaging or other flows using these solutions. And we don't know that yet. We need to start using them in order to do that. So this is data and analysis that I think is going to be very important to really tailor and tune the joint solution of the diagnostic workflow at the hospital with the tools, including AI.
Thank you, Klaus.
I will inject another question. So we talked about incentives. I like incentives a lot. If you set them up right, then that's a recipe for sustainability. And Bigpicture has a sustainability work package working to develop business cases going into the future, ensuring that whatever we build today will still be around in the future to add value to all the sectors of society. Having some insight into this validator thing you've been talking about here, the VIB, I know, making another parallel to Bigpicture, we also have a regulatory driver ambition within Bigpicture to make sure that the value we make can be turned into more value in more areas without getting tangled up in regulation that is hard to understand and navigate. Could you say a few words on the sustainability plans and the regulatory framework for the validation incubator and the environments that you are building?
Yes, so I think, you're talking about how to now go from this currently a research project. This is in Sweden, and partly due to GDPR, partly due to the Swedish patient data law. The only way to get started with this project is to define it as a research project. Then you can handle the sensitive personal data and try this out. But that is not a sustainable model. It has an ending date. So we need to address several aspects to it. We need the right owner of this database and service. That in Sweden, the other, apart from healthcare in itself, the other type of operations that you can have that is allowed to handle sensitive personal data is the national quality registries. So that is the legal shape that we're aiming for a sustainable model of this, that the data will be treated as a quality registry. We think that legally that's perfectly fine, but I think we will hit a bit of tradition clash, because all the other quality registries are defined for different purposes, and what the high quality of a quality registry in Sweden in general is to have all data for all patients in it. But in this case, we are just focusing on the purpose of validating AI, so we just need a representative data set. And I think that's going to be a bit of communication around what we are doing in this case. And then you have the funding part. I mean, it would be great if we could just have a big national government funding, and they realize that this is a part of a national infrastructure that they need to fund. We are not there yet. So for the time being, I think we will need to have pioneering care providers that will kind of see for their own benefit, they will need this, and then also being able to provide the services to others and make a viable economic case out of that.
I saw a hand up from my valued Work Package 2 lead colleague again there. Hello, Moritz. Would you like to ask a question?
Well, yeah. So if I understood you correctly, Klaus, you said one of the primary values for the companies, for the AI companies, is that they can be sure they have this data and that they have consistency for later reevaluation and so on, right? Is there a specific like how do you plan? I mean, I guess it's partially answered by what you just said about the quality registry part, but how do you make sure that it stays the same? Like how do you make sure that it's that they can rely on the data being there, because you have patient data, right? So it could be taken away for GDPR reasons. I guess only individual cases most of the time, but theoretically possible. And I think they can download the data, but as with Bigpicture, as we had the same discussion, data could vanish later on if mistakes are discovered and so on, right? Yeah, sorry.
Yeah, so they're not allowed to download this data. So it's they would just provide their models, and the models will be run organized by the platform, because otherwise we can't trust that they won't use the data for their training. So, but then yes, there is going to be a big part of this registry. How do you deal with making the first version of the data set is easy, and then you want to make sure that it's up to date with whatever new equipment is out there, and how you deal with the version handling and comparability and traceability for old analysis, etc. That's going to be a big part of what this organization operations deal with on daily basis. But lots of interesting analysis that is being done now for this first batch data collected.
Okay, so you don't have a magic solution either. That's good, perfect.
I'm afraid not. It's going to be just hard work and some compromise, but yeah, just.
Thank you. I see Paul has his hand up.
Yes. Yeah, I also have a question more on the value for companies, because there's a lot of questions about this, I think. Other than the fact that they're able to valorize their algorithm, can they leverage this fact in another way? Is it like in terms of marketing, or looking broader than that? Do you have examples of how they've been able to use this validation service for broader commercial purposes, or at least company purposes?
Yeah, we thought a lot about that. It's a bit too early for seeing that being used yet, but we for one thing, I mean, it's not so nice for a company to come and get validated and then turn out to be not the number 3 in the ranking and stuff like that.
Mm-hmm.
So we have definitely a trust issue that needs to be handled, that we cannot be too detrimental to the services by whilst at the same time being transparent. So, but we found the way we think about this is actually going to work pretty well, in that we're thinking more of a safe to use stamp. So it's kind of a informal certificate that we define some kind of threshold. This is good enough for use in Sweden. And then you will always find small differences, but that's also been the finding here in the work so far, that all the vendors that have engaged, they are all across above that bar, and slight differences, but each and one of them would be I would be able to recommend all of them. So, and then you have details to knobs to turn depending on what you want to optimize. So that's one way to give marketing value back to them, that yes, safe for use in Sweden. Nobody is going to be fired for buying from you in Sweden if you get this. So that's definitely something. And another observation is, of course, also that depending on your status on the market, actually the number one company that is most mature and feel that they have most clinical evidence already was not among the 3 first that joined this platform, because they probably felt that there's only a downside to being compared. If everybody already sees that we are number 1, then yeah, we can leave it at that. But that's so if you're a newcomer, then that stamp would be much more important. But we also see that as this goes along, everybody sees this value of getting the feedback on their model. So what this team produces and gives back to the company is a 100-page report on how you perform on different aspects without giving them the data. You have so much input to your own development process from that analysis that I think is going to be absolutely the most value for anyone joining.
Very interesting. Thank you.
So at this point, I will inject another question here. So thinking ahead a bit and assuming the quality register route will be fruitful, we've mostly talked about the mammography part so far for the validation stuff, but there's also other environments being set up, even though they're not as mature. Do you foresee that there will be an AI quality register and we combine multimodal data into that? Or do you foresee that this will take different paths and one for pathology, say one for radiology and or mammography or so on and so forth?
I mean, that it would be really cool if we could have a multimodal thing. And I mean, we've had discussions, especially within breast, that we have pathology there as well. So I think that it will be different solutions for different areas. I mean, one wow factor would be to get that integrated aspect, but it might be that more practical considerations, such as which care provider is willing to take on this specific registry part, I think might be more important to get something off the ground. So again, one might have to do some compromise, but so I'm really foreseeing some kind of ecosystem, but it would be really great if that would, as centrally, nationally, and even internationally harmonize and synchronize with all the lessons learned from the different places, and that can be shared effectively, even though formally they might be hosted by different organizations and yeah.
And another question might be, I sort of get the idea that mammography is fairly highly standardized. It's fairly well understood, whereas the field of pathology might be less well understood, less well structured, well standardized. How do you intend to tackle the challenges there, and does it relate to Bigpicture in any way?
Yeah, so one of the smaller pilots is in pathology with focus on breast pathology, and what we're seeing there is yes, same type of marketing message and CE marked products, but when it goes down to the practical details of actually doing the integrations and putting it into a clinical workflow, it's much less mature. So quite a long way to go in that sense, but so we don't really have that well-defined idea of what this validation platform would be in pathology. But then I'm foreseeing, I mean, this is definitely a big picture issue as well, and foreseeing an ecosystem where both Swedish and other countries would definitely use the Bigpicture platform for this in the long run. And I think that's also what will happen with the European health data spaces is I guess there's different visions of that, but in my head, that's an ecosystem of synchronized but separate entities and services that work well together.
So looking at the time and looking at Paul, I seem to remember these webinars being around 45 minutes long, but I think the calendar invite was for a full hour. Is that correct?
You can do one more question, Joel.
Right. Do I have one more question? Let me see.
Or anyone else, if they feel the urge to ask a bit more to class. And I think we're out of questions. I look back at a very nice and interesting session. Thank you, Klaas, for presenting and sharing to us about AIDA. Joel for moderating. I'll continue with some of the other business. I think these webinars are very crucial to building us as a community, to sharing information, to learn from each other. So if there's anyone in this session that feels an urge to also present on something he is doing which is relevant to Bigpicture, do reach out either directly to me or to bmo@bigpicture.eu. And then we also have another upcoming webinar on open source tools in digital pathology, presented by our former Bigpicture colleague, now working at Pfizer, Andreas Poelman. And this webinar will be on Friday, the 27th of October at 3 o'clock again. So thank you all for attending, and enjoy your weekend.
Thank you.
Thank you. Bye-bye.
Thank you.
Thanks a lot.
Bye-bye.
Thank you so much.
Bye-bye.
Take care.